you the first speaker who talked on hypotension and brain, Dr. Geraldine Mayana.
Thank you so much. I thank you so much for this invitation, and very nice to see all of you guys at 1 p.m. It's always a challenge after lunch to talk, right? So good luck to the other two. All right. Talk about the hypotension and brain. I suppose it was a kind introduction in my part, which I didn't hear. I'm sorry. Thank you for that. So some references, we did actually author a chapter in Principles of Critical Care. You might want to buy it. It can be hacked also, honestly. And then at the same time, all the references are here. So just an outline, quite straightforward. Just enjoy the talk. Must know all about perioperative hypotension and how it actually affects the brain. Then, of course, the importance of bedside recognition of hypoperfused brain. Is there really a monitoring? Is it available? And so on. And then, of course, take-home message. All right, normal values. So it's, who loves neurology? Raise your hand. I'm sure you love neurology. All right, one person who is my friend over there. Probably you love me, right? Okay. Anybody else who loves neurology or who got UNO in neurology? A little bit of basic on neurology, at least to have all these numbers inside your head. Cranial volume, 1,500, brain volume, 1,200. I need to go through it so you have a little bit of review on how the brain works. CSF volume, of course, 250 ml, ventricular volume, 125. CSF production rate, 250 to 500. You can kill yourself for that. Sometimes it's 500 and so on. How about the whole brain? You want to maintain a cerebral blood flow of about 55. If there's a number in this slide you want to remember, it's actually 55 milligram per 100 gram per minute. And this is practically 20% of our cardiac output goes to our brain. Very nice. Another number that you want to remember is actually cerebral perfusion pressure. It's 50 to 150, all right? Then of course you have cerebral metabolic oxygen reduction as well. All right, so I invented an E strategy for you guys to take home. For us to preserve our brain. We love electronics, right? So we go by E strategy, but the spelling on the I, forgive me, it's so hard already to place it. Excellent history and PN neuro exam. You cannot get away without doing a quite simple neuro exam, actually. And I'll show it to you later. That's a must. Seizures, of course, at the back of your head. You have to make sure there's no seizures. Temperature as well. We know for a fact every time there's fever or hypothermia for that matter, it also affects the brain. Quite sensitive. Respiration from oxygen to CO2 again. Agitation, sedation, we love sedations. Timing, all right? Remember, my topic is hypotension and brain. Timing, all right? And the duration of it. You want to have this very, very short, as much as you can, in terms of hypotensive duration. Of course, excellent BP. This is where we're going to focus today. Glucose, don't forget about the sugar. And intra-op monitoring. Is there a thing, or are we waiting for it, or can we invent it? So if there's again a graph or a slide, then you can skip the rest of my slides. But this is the most important thing, is the monitoring of cerebral autoregulation. Take a look at this. From the CPP of about 50 to 150, very nice cerebral blood flow of about the 50 milligram per 100 gram per minute. Very well targeted. But take a look at the 50 below. Take a look at the 50 below. Oh boy, take a look at the vessels. It collapsed. How about on the other side? Of course, everything is balanced when it comes to the brain. So we actually have a leeway of 50 to 150 to maintain very nice cerebral blood flow. But don't go down too much, nor do go up too much. How about this one, the effect of the CO2, the O2 to all this perfusion? Again, take a look at this. From 50 to 150, very nice, all right. But once you bring down that blood pressure, what happens to the brain? Hypoperfuse. Suddenly, patient strokes out. Okay? How about on the other side of the coin? Also, not a good thing. So I love this slide because it tells us, do we actually have a stroke patient or a normal patient? So prior to giving all this medications, we need to understand how each patient of ours actually works, how their brain works. Is your patient a post-stroke patient? Is your patient an elderly? Is your patient has syncopal attacks? Do they have dizziness? And so on. Take a look at this. Once you have a mild stroke, what happens to your map? It's actually somewhat dependent on the cerebral blood flow, on the map itself. Look at the cerebral blood flow to maintain that if you have a mild ischemia. And if you have a severe ischemia, what happens to your brain? It's the map, the cerebral blood flow is so dependent on the map. But take a look at the normal people. Normal people, that's us. Take a look at the green one. You want to maintain again a 50 milliliter per 100 gram per minute. About, again, a limit of about 50 to 150. But 50, you're pushing it, all right? So be careful. And then if you're a hypertensive patient, look at the red one. Okay, I'm shaking because I lack food, all right? Sorry about that. But you guys are so unresponsive, no? Like, ko siya nagre-react. It's good to react, it's fine. All right, hypertensive, the red one, when you look at it, the autoregulation curve, as we all know, moves to the right. The requirement is even higher. So if you're falling into 50, come on, we might need to go around this area to the brain at least. Make sense, my friends? Do I hear yes? Yes, lovely. It's nice to have response. How about here? Consequence of hypotension, reduction of CPP. Now you want to maintain cerebral perfusion pressure. So what happens, all right? So when you have an ICP that's normal, your map is so beautiful, you have a very nice CPP. This is what you want. But then again, if we induce hypotension, what happens? Our ICP goes down, our map also goes down, and your CPP is only at this level. All right? So be careful, again. So what is hypotension and how frequent do we actually encounter this? Okay, so definition first. So intraoperative hypotension was defined as any less than 90. But I'll talk about MAP. You know, when you look at the machines, this is not reliable. You have to compute for the MAP. All this Philips and so on. You have to compute for the MAP. And ask your resident to compute it for you because this is the most important thing. It's not only the SBP. If your diastolic is really down, it doesn't make sense. Putting all your eggs in the numerator. Nope, nope, nope. It doesn't work that way. The electronic anesthetic records display the hemodynamic parameters once every 5 minutes, and every displayed reading of SVP less than 90 was counted as an episode of induced hypotension. Ideally, of course, we know rhythms, and then you want to check the blood pressure. Ideally, you do have an A line. So this will be still healthy. Make sure the waveforms are there, right, for you to depend on it. Again, outcome of all this hypotensive, what happens? From hypotensive went to cardiac arrest, okay? And this is hypotensive. So death on table, 11, and then hypotensive. They're not zero, you know, even though they're small in a big scale, maisahan lang tayo ng isang patient, and it's really very traumatic. After you wake them up in post anesthetics, they don't wake up, nor they have plegia, and so on. This is a no-no, all right? At least do our homework and do our best to protect the brain. Are procedures different in terms of the outcome if hypotensive episodes are not controlled? So phases of anesthetic at detection of hypotension,